Okay, thank you very much. Namaste to all of you. A very good morning to all of you from Lucknow. So myself, Dr. Surya, Professor and Head Department of Respiratory Medicine at King George's Medical University, Lucknow. And traditionally, we call the moderator for a debate, but this time Chess Council of India has called me as referee.
Oh.
So I take the oath of being very neutral, act like referee. So thank you very much, all the leadership of Chess Council of India and the organizers of today's debate. That is a very hot topic. You see, in Lucknow, the temperature is 47, 48, I think, but again, we are going to observe the more temperature than the Lucknow temperature in this debate in 1.5 hours. Because two important stalwarts in the field of respiratory medicine of India are here to put their viewpoint on the very important topic that is COPD. And the H.G. Varudkar from Ujjain, which everybody knows, it's a famous for the one of the important Jyotirling, Bholenath. And another speaker would be Dr. SK Chhabra, who has been in Patel Chess Institute and right now he's in corporate practice. So two stalwarts will give the viewpoint on the two aspects of the COPD. So I think the COPD is a very important disease throughout the world and in India also. If you just go in the history of COPD, the first of its description, not as COPD, but like that, goes way back in the year 1679, in the last of 17th century, when a scientist called Bonnet, he described this entity as voluminous lung. This was the first ever description which may mimic like COPD, or you can correlate with COPD. Then, of course, the history of 200 years. And this 200 years, the term chronic bronchitis came first. This came into a year that is in 1814, that is early 19th century. So around 200 years back. And this term was described as chronic bronchitis and bronchiolitis, and the usually symptoms described as catarrh, bronchial catarrh. Later on, the name was given. Now, of course, with the advent of the stethoscope, because before 200 years, the only method of making a presumptive diagnosis was the history and physical examination. In 1821, that is the landmark in the history of medicine, when Linnaeus described the stethoscope, that is the most important ornamental of all physicians of the world. So usually, like females, they like a lot of ornaments, golden ornaments and so many ornaments, but we like one ornament, the doctors, the physician, that is called a stethoscope, described in 1821, just 200 years back by Linnaeus. And then the diagnosis of COPD became not exactly termed at that time COPD, that became like the combination of history, physical examination, and the practice and use of a stethoscope. And later on, another gentleman, John Hutchinson, after 25 years of discovery of a stethoscope, discovered the spirometer in 1846, mid of 19th century. And that added to the diagnostic value and importance and efficacy of this disease. And later on, in 1962, means mid of the 20th century, American Thoracic Society first time gave the description of three components of very important obstructive lung diseases, that is chronic bronchitis, emphysema, and asthmatic bronchitis. They were clubbed together. In 1962. So I think Dr. Varudkar will utilize this background from the voluminous lung to the three components of COPD that were described in 1962 as chronic bronchitis, emphysema, and asthmatic bronchitis. And later on, the various development. I will not go into the detail because the debate will describe them. So I think now I invite the Dr. Varudkar. Varudkar is the faculty and professor at the Gardi Medical College,
Medical.
Ujjain. So, Dr. Varudkar, it's time now for you. He will speak on there is nothing called COPD. So he's a speaker for pro, and Dr. Chhabra will speak against this. Yes, Dr. Varudkar, over to you.
Are you getting my screen sync? Hello? Thank you very much. Are you seeing my screen? Hello?
Yes,
Atri?
I can see your screen. Yes. The first slide is there nothing like COPD. Yes, question mark.
Yeah. Well, let me clarify some of the things in this COPD context. See, because this has bothered me about 22 years, right from the concept of COPD, when I heard from Dr. Salve about this. Gold guidelines has to be covered because it is I mean, actually pervading all over world, influencing all over world, and you cannot have discussion avoiding gold. It has to be necessarily covered gold because that is only guideline all over world practiced by the all chest patients. So we should be wide, I mean, broad-minded enough to understand what are the pros and cons, what are the other views about this COPD, and what is the really a problem. Are they going all right, or we are just pretending to be fine? We are pretending to be very wonderful things. Are we going to anything? So without any personal, I mean, personally damage and personal classes. I want to put my views straight across you people, so that you will understand what are my views about it. Okay, so I cannot. Nobody can talk COP without mentioning gold. That is really a problem of our subject. So I sorry, I will have to cover this particular topic in that particular reference only. So, are you getting my?
Dr. Varudkar,
Yeah.
your slides are not changing. Change the slide.
I have changed. I have changed, but actually they have gone.
But we can see only first slide.
Oh,
We are seeing only first slide.
stop share. Okay, right. All right. Yeah. So you want screen? Yeah, that is there. Okay. Now,
Yeah, good, very good.
okay.
Yes,
So
now
this is
I can see your degree, PhD, MD, DCD. What is this DCD?
diploma in chess. This is the
Oh,
University
diploma
of
in
Pune.
Chelsea. Okay, okay,
Right.
okay.
That we have
Okay.
covered almost all spectrum of degrees.
Yeah, from
And
diploma to PhD. Okay, great.
diploma, degree, and doctorate. So both all the things. Now I am just retiring in my comfortable life in Pune. However, my
Okay.
spirit of academics has not ceased. We just want to continue
Yeah,
struggle with the things, and
that's good.
let us develop our speciality in a more healthy way, more beneficial to the patients, more sound in academics. Hmm. No, so let us go to. There are some caveats before I start everything. COPD, as I said, it is chronic obstructive lung disease, pulmonary diseases, and it is relevant to the concepts of gold guidelines, which I already emphasized that why gold guideline is very important in every discussion, and it has to be covered in all angles, not only positive. We have to cover in every angle, whether practical, patients, society research, and everything has to be covered. And that's why I am putting my views honestly straight across the table. Now, before gold, what was this? And there were multiple names. Chronic of already Suryakant has enumerated them, but let me complete it as a part of my presentation. COPD, COLD, COAD, chronic airway disease, so many things. And amongst all that, what was the problem? Chronic bronchitis and emphysema were the main problems. So what has become? There were some drawbacks. There was quite of overlap was there. There were no clear-cut nominations. There was no clarity of the disease, and so many things were there. More problem that the health authority did not appreciate the true volume of the health burden. That was again important. So gold has to be in picture. So here comes gold for solving the problems in COPD or chronic obstructive lung disease. Now, what has happened? Gold has defined very categorically. It was a need of activity. So, what are that? So, to avoid confusions and to uh, draw attention of the world, the authorities. Okay, that was it. Just a minute. So there's a definition. I'm just putting only important salient point. One, airflow limitation that is not fully reversible. Right. Then this is confirmed by spirometry. So that is has to be confirmed by spirometry. Then it is post bronchodilator FEV1. That is important. So I am repeating most of the time same and same because our definitions are based on this particular thing. So again, at the end, I am stressing about this, not fully reversible with bronchodilators. Okay, this is the definition. Now, in addition to these things, gold has created some funny situations. So what is that? This is very problematic. What was that? They have used these messages are directly, they were directly in the beginning, and they are percolated in the various literatures that do not use chronic bronchitis, do not use emphysema, do not use any other concept. So this has been categorically instilled, infiltrated into medical fraternity. And what has happened because of that? Now all variants which are to be accommodated under one shelter, and that is a brand new entity called as COPD. Now we don't have anything. Now by having COPD, what has happened? These are the references. What I am saying for that. These are directly or indirectly covered. Whatever information I am putting. Now, what has happened? This is a very good news for our students. We don't have blue bloaters coming out of chronic bronchitis. We don't have pink puffers because our teachers don't harass them by asking what are the references. The theoretical questions are not there. Very good achievement for students. But what has happened in that situation? The wide gaps have remained and they are not answered. What are the wide gaps? The diseases are classified on the basis of pathology. That is important, not be any arbitrary mechanical things. So, what is the basic pathology of the COPD? You will know there is a wide variation in the pathology. So, that is not one pathology in this, it has to be covered. Then, if it is irreversible airflow limitation is the basis of COPD, then what is the position of reversible non-asthmatic airway disease? There are many diseases are there where reversible. Are they covered? What is their position? So they are just to be bundled in one particular thing, or you want to put in a separate thing. So they are not there because there is a reversible airway of it. So what is to be done with that? And what are the alternative provisions made in the new concept for all variations? Well, I say I'm afraid there are no answers are no for this particular thing. So the classification of pathology, these limitations, airways, alternative these points have not been covered for last 21 years. You forget about first year, second year, third year, but for last 20 years they have not been nicely covered. Now let us go to the scientific problem of F1 upon FPC ratio. Fine, it is only diagnostic criteria, but it is affected by man, machine, all so many things. You cannot be ideal like in Western country, America or Mayo clinics. You go to a Lucknow and remote places, UP, Bihar. There are so many factors. So what have to be done with that? Okay, fine. We'll pardon that particular thing. We'll correct it with our thing. But lack of specificity and sensitivity is a very important thing. Say respiratory symptoms were common in current or former smokers despite normal FEO1, FEC and FEC values. This is one study, there's a reference are there, but it's just I'm mentioning the observations, how they are problematic. So FEC, FEO1 upon respiratory is normal, And then just the symptoms are there. What is their issue? Emphysema is detectable even in spirometric and normal persons. Again, problems. So you have to consider this as a normal, healthy person, or again, what do you want to tell? Normal spirometric functions are reported even in presence of almost 20 to 25% of emphysematous lung. This is on CT scan. So and the last thing is that the gene study involving about 10,119 two smokers, spirometry missed about 42.3% of emphysema patients. So you can understand there is a big gap. There's something missing. So sensitivity is not all that good, and forget about specificity. There's so many things. So FU1 efficacy ratio is a lack of. Again, there's one more factor: low limits of normality, or all for one. What is to be done? If lower limit of normality is used, the recently Daniel has found the meta-analysis was there. So prevalence of COPD reduces from 7.4% to 6.2% just by classifying on the basis of low limit LLN. So we have 1.2% people have been made normal, declared normal by just changing criteria, arbitrary criteria. So what do you do this? Is it a good thing? So we were putting on their drugs by classifying them on so many things. 1.2% of the population. India has got how much? So how many people were labeled as disease persons? So again, reversible non-asthmatics is a problem, and no provision is made for that. So and let me just arbitrary. Only spirometry is not a good answer to the problem. Okay, and only FU1 upon FU ratio, well, it needs something more. So can we do something more? These are the references, whatever I said about my database. Can we use FU1 25%, 75%? This one thing. As you know, this represents the small airway disease. So is it going to be more used for the diagnosis of COPD? The concept we'll have to think over, but let us use this particular term as of now. So can we use it? So is it more likely to solve problems, or more stringent study can give better criteria for FU1 or FU20? I mean, if V 25%, 7%. So this particular test needs to be understood by all of us, especially by gold, because this is not no presentation given to this. Okay, so let us go to the other decision. Now the world has progressed so fast. We have got everything. We have got a bronchoscopy. We have got mucosal biopsy. We have got radiology. Radiology has done wonderful work. I mean, you just go to the CT scan. You go to CBS Abels, and they will literally classify your lungs in a very systematic way and perfect way. So are we not going to cover these things? Or you just want to stick to FE1 upon FE ratio? Are you not going to see? Why not to use these? This is going to be very useful, helpful for you. And what is the use of this particular? You, in the long run, you can say you have made wonders. Let's go to the treatment part of COPD. Recently, I have found that they were teaching slides of board. These are original copies. The management of COPD starts from the slide number 11, where the diagnosis, initial assessment, and those things are there. Now let us go to the slide number 21, 28. See, here they have pharmacological, and the group A, group C, group D, and this is no funny, where you cannot remember the things, you cannot, practicing clinician cannot use this table. Is now recommended here, but okay, we are at the receiving end, so we have to accept it. But now we have come to 28 number, and now here we have come to 36 number, and here it has come non-pharmacological management. So from slide number 11 to slide number 36, drugs, and all of them are bronchodilators. They have not left any bronchodilator available in our armamentarium. So, what is the rational? What bothers me here? What bothers? Why? I mean, if airways have poor reversibility in COPD, then why the bronchodilators are discussed as so rampantly? Why so many bronchodilators? So much emphasis, where there is no reversibility at all, or maybe poor reversibility. You add one or two bronchodilators, and here you have got a huge bulk of bronchodilators. Well, that is real bothers me. Are we really scientific in thinking, dealing our COPD concept? That is the actually by definition, COPD is a stage of withdrawing bronchodilators. Why? Because by definition we have seen that they are not responding. Bronchodilators are not useful. So look for more logical technique. COPD concept, the whole concept, we should have more logical. And then here comes the better subject for research. We can have more wonders by going in more rational way, instead of pushing a lot of bronchodilators in patients all over the world. So giving some benefit, some consideration to this aspect of our definition would have really yielded something else. It would have given something very different picture would have been arose by. But why we are all stuck up because we are strictly only COPD, only this particular thing, only in the era of our modern democracy, independent days, the gold is holding all in a very bad status of things. They are not allowing independent to work and think over it. This is what I don't like. That is the reason why. Now let us go to very important. Now research how research is in pulmonology going on. You see, you go to psychiatry, you go to skin. These people are going to split their disease. Hair splitting is done. They have a treatment only one or two drugs. You go to skin people, they have got only steroids or antihistamine. You look their books and then 4, 5 volumes, huge volumes. Why? Because the hair splitting of diagnosis, everything is done. And ours in pulmonology, we have got COPD, we have got DPLD. What is this? We should have better analysis, better decision, better breakup of the various symptoms so that what will happen? There will be better research. What has happened? Now let us go to research paper. Very amusing words are there. I read them. COPD is a heterogeneous thing. What is this heterogeneous thing? Already you have combined that blue bloater and pink puffer and some mathematics in this particular thing. It is going to be heterogeneous. How do you expect that? These are the remarks of frustrated research workers. So because he doesn't know how to interpret the observations. So next is we have seen this differences remain unexplained. It is common. We have seen differences remain unexplained. We have seen paradoxes are plenty. This and then there are COPD. It's a very curious condition. These are a few remarks. Why I'm telling you? Because our research workers are many times not able to draw very clear-cut conclusions. What is the reason? The reason is the basic concept is very vague, very vague. It has not classified, it has not subgrouped, it's not. It's a huge bunch. No, it is not going to, research is not going to yield anything good. It is all going to be stagnated. So, because the base of the research is all faulty. So, if you want to walk out of this particular condition, I will tell you, NAPCON, Mahesh told me about that 24,000, so many patients are on COPD. Huge bulk. What is use? If there is no rational thinking of these particular basic aspects of a disease, then natural research is going to be limited. So, for example, the person who has got a drug which is acting on, say, inhibition of mucus production. So, he is subjecting to your COPD concept where there are a lot of emphysema, dry, lung is dry. So how this man will be getting good consistent result? Naturally, it is going to be consistent, and then he will look for biopsy. Same way, if some drug is going to act on emphysema, so naturally it is going to be really problematic because we have not classified our COPD, our diseases in a very systematic way. That is the reason our research is stuck up. Our research has not progressed in the last 25 years. We are just there lingering. The research of CT scan, radiology, we are thankful that they have maintained that particular thing. We can at least classify as emphysema. We can classify as chronic bronchitis. The EBUS, there is availability. They can think the thickness of this, Reed's index, everything is there. But are we not able to you're going to get these particular things involved in the research? Or we just want to FU and FH ratio? What is this? Are we not? Our younger generation should think this particular aspect in a very serious way. I am not saying that I am a very wise person, but I am a basic thinker. I just want simple thing by, and then I don't want to be a very complicated thing. But you think over these points and give me answers. Now let us go to genetics. Genetics, you can think of genetics. That is going to be very important. But now genes of alpha trypsin has been identified convincingly. Okay, genes of emphysema, yes, to some extent they have detected nicely. Genes of even smoking, heavy smoker, especially they have been detected, identified. But gene study of COPD, what about this? It is still in dark. It is not giving good results. Why? Because COPD is all broad. It is not a good concept. So that is the reason why we are not getting way out breakthroughs. And now this Peter Burns is a very important, very big name in COPD, personality, towering, and what he has seen in a research paper, still understanding of cellular and molecular mechanisms in COPD is unclear. There is so much advanced microbiology, endocrinology, this and everything. This man is saying this conclusion. Several attempts have been made to distinguish different clinical phenotypes using cluster analysis. Again, you see. However, these clusters are not consistent. Actually, there is something not consistent between different studies. So what has happened? So what has happened? Even such a stalwart is frustrated. He is not able to get out of this particular problem of COPD because something is grossly wrong at the level root. So that has to be. Is it a poor man or is something else? He's a big man in COPD. Well, now let us go. What efforts have been made by Gould to resolve the differences, fallacies, paradoxes? Are you thinking? Because sometimes we go wrong. Well, next year we correct them. After 30 years, after 10 years, let us 2007, they have addition of at-risk COPD group. This is something new. And after 8 years or something, this is additional in the, and this is asthma COPD overlap. That is after 7 years, this has not much of dent in the progress. Just after some years again, 2011, what is an addition of comorbidities was. This is something new, addition of comorbidities. But has it changed really concept of your COPD disease or whatever? Well, I don't think you think over it. And after 8-9 years, what has happened? Addition of CAT assessment, ABCD assessment. Okay, so many assessments have come there. You must have seen there. Is it going to be useful? Are they going to make a dent in the diagnosis? Are you going to correct it? Or are they going to make more complicated things? Is a common practicing physician going to practice it? I'll tell you, I have read a lot of literature about asthma allergy. There are about 260 asthma guidelines. The bottom line of this guideline is not a single guideline was used, practiced by the physicians in practice in the field, and the makers of guideline themselves have not practiced it. Well, this is a statement in relation to asthma. Some years ago, I read it because I wanted to do research in the for PhD. So, are is the whatever guidelines are they really practiced by the remote test vision in the world, in the this country? These are the questions to be answered by all of us. So I suppose burning problems of this have not been solved by changes. So I was very brutal, very brutal. This was the last bit I just suggested in the, we should not have, but I am little more considerate. Why not to have more things about this? And so, friend, this is the reason why I am saying that COPD needs a drastic change. You people, actually, the main idea of involving CCI is we have got large young people with dynamic, dashing, and open-minded. They should be informed, aware that these are the problems with these are problems I faced. These are pinching problems to me, and that is the reason. Okay, so I'm thankful to CCI organizers to give me this grand opportunity. You have listened me very nicely, patiently, and well, this is nothing personal. This is for the betterment of our science. This is for the betterment of our society. Let us go for the better things. Thank you very much.
Thank you, Dr. Varudkar. Thank you, sir. Thank you very much. Dr. Varudkar, you are retired as you mentioned in your introduction. I was thinking that still you are in Ujjain, but you have retired and you also
Yeah,
said
I
that you
mean,
have been professor and head of different medical colleges. So you have the
yeah,
experience of
yeah,
different flavors. In
yeah.
Hindi
I
में हम
was
लोग कहते हैं घाट घाट का पानी पिया
बहुत
हुआ है. So
बहुत
know
पिया
the
हुआ
flavor
है.
of every area of border.
Right, sir. Right, sir.
And
Thank you.
you are retired but not tired. Not does not appear to be tired. Still you are active,
I
very active, and really I want to
thank you.
congratulate
Thank you very
that
much.
you are academically interested.
Thank
Not only academically interested, you are thinking in terms of 360 degrees. So thank you very
thank
much for your viewpoint on this very important topic. Now it's time for the Dr. Chhabra, Dr. SK Chhabra. Please come forward for your viewpoint.
Thank you, Dr. Surya. I think Dr. Varudkar's presentation is still on. You'll have to stop it first.
Dr. Varudkar.
Stop. Right. I got it. Okay. I did it. Yeah.
Right. Presentation visible?
Yeah. Let full screen.
Okay. I really enjoyed Dr. Varudkar's talk, and I have known him for many years.
Thank you.
One good thing about Dr. Varudkar is that he likes to swim against the tide.
Chhabra will speak on the counter of Kant's
Thank
part
you.
of the topic.
Nature is bad.
May I start, Dr. Surya?
Yes, sir.
Okay. So,
Your time.
As I was saying, I've always enjoyed Dr. Varudkar's talks. I've known him for many years. And the reason is that he prefers to swim against the tide. Very provocative, very bold, and that sets the tone for a debate. And that is a primary requirement for a debate. If there is no spark, then it doesn't become a heated debate. So thank you, Dr. Varudkar, for setting the tone for the debate. Now, our topic was that there's nothing like COPD. I was expecting that perhaps an alternative terminology would be introduced, or there will be some reasons why the term like COPD should not be there or should be modified. A lot of discussion on gold. Specifically, I'm not touching gold because that is a slightly different topic, but since a few arguments have been raised against gold, so I would be answering those also. Now, when we say that or claim or make a bold statement like there's nothing like COPD, and in a clinic one comes across a 50-year-old smoker complaining of dyspnea on exertion, which is progressive, the chest X-ray showing hyperinflation, spirometry showing severe obstruction, then what do we call it? What is the label to be used? There has to be a diagnostic label. So is it not COPD? So it's not that we can just dump COPD. Slide is not moving. Yes.
It's not full screen.
Yes.
Okay.
So that statement that there's nothing like COPD was a bit intriguing. So I thought, let me find out what the word thinks about this statement. I entered the word COPD and also chronic obstructive pulmonary disease in Google, and the results are mind-boggling. 1,620 million results about COPD and 291 million results about chronic obstructive pulmonary disease. That is the extent to which every day people search about COPD. Then PubMed, searching about how many articles have been published on this disease called COPD, 99,680. So a huge amount of research is going on in COPD. So clearly the world agrees that there is a term called COPD and it is there to stay. We are not looking for an alternative term. Now this figure is very illustrative. We notice these are the number of publications per year right from 1945. So each year there were a few hundred publications till the turn of this century. And then around 2000, 2001, there's a very sharp increase, almost 10 to 15 times increase in literature. This 21st century boom in literature. Why this has occurred? This has occurred because COPD has come to be recognized as a specific disease. It has come out of the shadows of asthma. Earlier, there was a very negative view about COPD, that a bad asthma, not responding to treatment, is COPD, and there is no treatment for the disease. Gold brought a sea change in our concept of COPD. It made us think positively about COPD. Not only that we can prevent the disease, but we can also treat. And preventable and treatable are important terms which have been introduced in the term COPD. So this huge boom in literature is thanks to the coming of gold. Gold was formed in 1997, the collaboration of National Heart, Lung and Blood Institute and WHO, and brought together healthcare professionals and public health officials around the world because of the worsening epidemiological scenario. Diseases like coronary artery disease, stroke, all these have shown a downward trend in the last few years. COPD is the only disease which keeps increasing every year. So clearly it has become a huge public health problem all over the world. So to raise awareness about the disease, to improve prevention and treatment, and to develop evidence-based strategy documents. The goal is not a guideline. They use a term strategy document. So it defines a strategy which is based on evidence, and they encourage local adaptation because there are local requirements in each country depending on the culture and access to healthcare facilities. So local development based on a common strategy which Gold has evolved, and that is evidence-based. Every year it is updated and revised. Whatever work is going on in the field of COPD, that is include the important ones. So it has become an encyclopedia on COPD. In fact, for an average clinician, even a pulmonologist, he need not go to another textbook unless he's doing research in COPD to read about COPD. I love to divide COPD into two eras. One is pre-gold and one is gold era. That has been the impact of gold on COPD, our concept of COPD. So this literature boom which came around in 2001, this led to a complete change in our understanding of COPD. What we know about etiopathogenesis, about pathophysiology, diagnosis and assessment and management is completely different from the previous century. So we can definitely say that there's no disease like COPD was in the 20th century. The COPD, as we know now, is a totally different disease, thanks to the literature boom led by Gold. Dr. Surya mentioned the historical evolution of the concept, and that is a very useful review to understand how this concept of COPD has evolved over the last few centuries. Chronic bronchitis and emphysema, these were the initial terms which were used way back in the 1800s and even earlier than that. Emphysema was recognized. Then Laennec described a combination of the two for the first time. So that may be taken as the first documentation of COPD, because COPD came to be understood, although the term COPD was not used at that time, as a combination of components of chronic bronchitis and emphysema. At that time, we only had Laennec's stethoscope. Then John Hutchinson invented the spirometer in 1846. And it was not for another 100 years that Tiffany developed the concept of timed vital capacity, that is measurement of FEV1. So the concept of FEV1 as a measure of airways obstruction came to be established in 1947. The two terms, chronic bronchitis and emphysema, these gained currency from that time onwards. Chronic bronchitis was described historically, and all the questionnaires, even the questionnaires that we use till date on epidemiological studies on COPD, we use these questionnaires which ask about cough, expectoration lasting 3 months and a year for 2 years, and that defines chronic bronchitis simply by history. Emphysema is a morphological term. You require a biopsy or a lung specimen to diagnose emphysema strictly. Later day technological developments allowed in vivo studies of emphysema. So today, CT imaging and diffusion capacity measurements can reasonably tell us that emphysema is there. So chronic bronchitis and emphysema, these existed in different combinations. So to put things in proper perspective, two landmark meetings, the SIVA Guest Symposium in 1959 and American Thoracic Society Committee on Diagnostic Standards in 1962, they defined three terms. Dr. Surya has already alluded to these terms. Chronic bronchitis, which I have just said in historical terms, emphysema in anatomical terms, which meant that you require an anatomical tissue at that time. And asthma was also included in the spectrum of these diseases. And asthmatic bronchitis term was also introduced, and which was a precursor to the later day use of the term ECOS. In literature, different terms have been used: chronic obstructive bronchopulmonary disease, chronic airflow obstruction, COLD, these kind of terms. And the term COPD is believed to have been used for the first time by William Briscoe in a discussion in the 9th Aspen Emphysema Conference in 1996. So that may be read as the first time the term COPD was established. As clinicians, as a beautiful slide shown by Dr. Varudkar, we have been taught about blue bloaters and pink puffers, chronic bronchitis, corpulmonal blue bloaters, pink puffers who huff and puff but do not go into cyanosis. And COPD came to be recognized as a combination of these two diseases in different proportions. Some people have more of chronic bronchitis, some have less of chronic bronchitis, more of emphysema. So that's how in last century we used to look upon COPD. So that is the pre-gold concept of COPD. And as a medical student and postgraduate, this is what I learned in my post-graduation days. Then the American Thoracic Society in 1988 and 1995 came out with further refinement of these terms, and they introduced what is known as non-proportion Venn diagram. This is a very, very landmark paper. This diagram is one of the historically preserved, one of the best diagrams, and this shows the different subsets of these diseases. And what Dr. Varudkar said, that there can be patients with emphysema without airways obstruction, or patients with symptom of chronic bronchitis with a normal FEV1 by FVC ratio. All this was captured in this Venn diagram, because this horizontal rectangle here, this is the subset of patients with airflow obstruction. So even in 1995, before gold took birth, it was recognized that there can be patients with chronic bronchitis, with emphysema and asthma who do not have airflow obstruction. So we cannot say that this is a limitation of gold. This was there, recognized in 1995 as well. And then gold came. Gold changed our concept completely. came around in 2001, the first strategy document, and it acknowledged COPD as a specific disease. The terms chronic bronchitis and emphysema were abandoned. Reason, emphysema cannot be diagnosed, and Gold was catering to a mass base of patients, to all levels of healthcare, to primary and secondary levels of healthcare. It was not a guideline or a strategy document to be implemented at a tertiary care center. This was something which the primary care physician could use. The reason was that the number of patients was huge, and the majority of patients of COPD are seen actually by primary care physician, not by specialists. Asthma was excluded because at the same time, GINA had come. So asthma was taken out of this umbrella, and COPD was described for the first time in functional terms using spirometry. So in 2001, COPD was defined as a disease of airflow limitation that is not fully reversible, which is progressive. And then they use a term, abnormal inflammatory response of the lungs. This again was a sea change from the previous concept. And it also recognized the importance of environment in the precipitation of COPD. That the inflammation is produced as a result of noxious particles and gases. So it established a link between environment, including passive smoking and biomass fuel exposure, and inflammatory response. And it also defined the diagnostic criteria of FeNO by FVC less than 70%. Now, I may halt here and just comment on what Dr. Varudkar has said about the diagnostic criteria being not good. We all know that it lacks sensitivity and specificity. But the objective is not to diagnose 100% patients of COPD, but to diagnose the vast majority of patients so that they can be given the right treatment. There would be some patients who would be missed, definitely. And if we use the lower limit of normal criteria, then you require local equations first. That will definitely improve the sensitivity. But Gold has considered this debate of lower limit of normal versus the 70% criteria and said that the fixed separation by 70% is used because of pragmatic reasons, that it is practical. FEF 2575 as the measure of small airway disease was given up long back in the last century. And other diagnostic tools like EBUS or biopsy, they have no place in COPD. So the only way that COPD can be diagnosed is by spirometry, and that is the definition of COPD, which has come to stay. Now, a clinician who is using this definition, he has to use his judgment also. He has to rule out other conditions which are going to cause this kind of ratio. So it's not that it's only the ratio which is used to diagnose COPD. Then each year, the definition of COPD changed, and in 2022, now if you compare this with 2001, it's widely different. And the most important change to me is that the term inflammation has been given. And this is consistent with the change in management. There was a time when COPD was managed just the way asthma was managed, and inhaled steroids were very popular. But the adverse consequences, especially the frequency of pneumonias in COPD, that led to a reconsideration of use of steroids and shift towards bronchodilators. So the word inflammation is now taken out of the definition. And then look at the positive aspects of Gold. The disease is preventable. It is treatable. Then it talks about airflow limitation being due to airway and alveolar abnormalities. So my friend Dr. Varudkar said that the basic pathology is not defined in Gold. No, it is defined. It is the airway abnormality and the alveolar abnormalities which are causing the airflow limitation. The role of environment retained there. So that is the huge role of smoking. And if you look at Dr. Salvi's papers recently, the role of non-smoking exposures, the biomass exposures leading to COPD, that has gained currency recently. Then host factors. The genetic factors are acknowledged, but research is going on. We haven't identified the specific genetic abnormalities. It may be polygenic, but definitely the disease and its predisposition starts not in middle ages and elderly, but in childhood. And that is again a new concept in COPD, that the vulnerability is there in childhood, abnormal lung development and host factors. And later on, when the right environment is there or the wrong environment, that precipitates COPD. The other recognition is of the significant comorbidities. That while COPD is an airway disease, a lung disease, it is associated with extrapulmonary manifestations, complications, and comorbidities which have an impact on morbidity and mortality. So this description, this is very much like sarcoidosis. The entire disease is described in these 5 lines. That is the modern concept of COPD, much different from the ATS concept. If you just compare this with the Venn diagram, so that is how things have changed. And the boom in literature that has contributed to our understanding of COPD, and this is how we are defining COPD today. So the gold concept of COPD identifies small airways disease and parenchymal destruction, which is the equivalent of emphysema, as the main cause of airflow limitation in COPD. The pathophysiology is very well defined. We know that changes occur in mucus hypersecretion, there is airflow limitation, the role of hyperinflation, gas exchange abnormalities, pulmonary hypertension, systemic effects of the pulmonary inflammation. So all these are very well documented, and besides GOLD, there have been other guidelines like the ERS, ATS COPD guidelines like of 2005, which have corroborated what GOLD says. A word about whether COPD is a syndrome. Now, I have seen this term being used loosely, that because COPD has pulmonary manifestations, extrapulmonary manifestations, so is it a syndrome? So I searched for literature that what is the difference between a disease and a syndrome. A disease is defined as a condition that is marked by 3 basic factors. Firstly, it has to have an established biological cause behind the condition. Then there should be a defined group of symptoms, and there should be consistent changes in anatomy due to the condition. A disease usually has a defining cause, distinguishing symptoms and treatments. A syndrome, on the other hand, is a recognizable complex of symptoms and physical findings where a direct cause is not necessarily understood. Now, let us compare it with diseases like, let us say, SLE. SLE has manifestation in different organ systems, but it is a disease, it's not a syndrome. Similarly, COPD, it fulfills all the criteria of a disease. So it is not a syndrome, but a disease. Although we know that there is extrapulmonary involvement in COPD, there is core as a complication, risk of cardiovascular disease, osteoporosis, malnutrition, anxiety, and depression. But the primary disease is airways, parenchyma, and in the pulmonary vasculature. And it is well defined in GOLD. In fact, GOLD does not use the word syndrome anywhere throughout the document. So loosely, we do call COPD as a syndrome because of wide involvement, but because it fulfills all these criteria, there is an established biological cause, a defined group of symptoms, and well-defined treatment. So COPD remains a disease as defined by GOLD, and that is universally accepted. In fact, the GOLD, GOLD, is a perfect acronym for the concept of COPD. G stands for global, same problem, and it's a global problem. The O in COPD indicates airways obstruction. So we cannot, in our present state of knowledge, diagnose COPD if there is no obstruction. We do recognize, and this is recognized in GOLD guidelines also, that there can be emphysema without airflow limitation. There can be emphysema on CT without there being clinical manifestations. But we are talking about a disease which has manifested in the masses, in the huge numbers. And GOLD aims to pick up the disease in masses. So the obstruction, therefore, is necessary to establish the diagnosis. Its L stands for lung, and because it made a perfect acronym GOLD rather than GOPD, they couldn't have called it GOPD. So they called it GOLD because it's a very catchy name, but lung stands for pulmonary. And then D, disease. So the term GOLD itself recognizes that COPD is a disease. And like I said, GOLD document does not refer to COPD as a syndrome. I searched the whole text for the term syndrome, the 22nd 2022 guideline, but it's not there. So GOLD has been very dynamic. has changed from 2001 to 2006. And that is the strength rather than the weakness of gold. It is responsive to new evidence. Every year when a new revision comes, the first chapter lists what is new in gold. How our information has improved. Because the objective is to incorporate the recent advances and then take the research to bedside. So that is the success of gold. ABCD classification, that was introduced in 2011. The Varudkar says difficult to remember, but we don't have to apply CAT score in every patient. Even simple MRC classification, that is good enough to use ABCD classification. And MRC classification, every one of us is taught in our undergraduate days. In 2001, the ABCD classification also introduced the importance of patient-centered outcomes. That we are not focusing on spirometry to decide the initial treatment, but on dyspnea and exacerbations, which matter most to the patient. So this is a big change in our concept of sleep. And then over the years, bronchodilators have evolved as the mainstay of therapy. It's not that we have to look upon COPD as an irreversible disease. It responds very well to bronchodilators. In fact, bronchodilators are the drugs of choice. So there's nothing surprising if the guidelines now emphasize on use of dual bronchodilators as the mainstay in the initial treatment. Because bronchodilators, they produce what is known as a pharmacological lung volume reduction. They improve the quality of life. They improve exercise tolerance. They reduce it. And it's a good thing that has happened that we have switched our focus from steroids to bronchodilators in COPD. Because the steroids were realized to producing more problems than solving. So there is still a role for steroids. And since we are not discussing management today, so we are not going to that today, but personalized therapy is evolving. Just like in asthma, it is very well developed. It is early days in COPD, but recent guidelines in the last 4 years emphasize the role of eosinophil as a criteria to decide whether steroids have to be used. So we are moving away from a one-size-fits-all concept in COPD to a more personalized therapy. Gold is evidence-based and updation is a continuous process. We are understanding our phenotypes better, moving towards personalized therapy. So these changes are going to come in years to come. So should we give up the term COPD? Gold, we know, is COPD, we know, is a major public health problem. Millions die every year. So I will not repeat the sad story about gold. We all know it is grossly underdiagnosed and undertreated. Majority of physicians, especially in India, don't even use the term COPD. So it's not that they do not agree with the term COPD. They're not just used to making a diagnosis. Sheer ignorance and lack of access to medical facilities. So COPD is a disease which is causing havoc in our populations. It's a leading cause of mortality and morbidity now. And Dr. Salvi's article recently pointed that out. So rather than give up a term like COPD, we have to make sure that the message of gold reaches the primary health level, the secondary health level, and these guidelines are widely disseminated. Because the current and the projected epidemiological scenario of COPD is frightening. And thankfully, gold has brought a tremendous change to our approach in treatment of COPD from a nihilistic, negative approach to a very positive approach. So, the term that there is nothing like COPD, I would like to rephrase it. I'm not dumping this term because COPD is a dynamic term, it keeps changing. So what I can say is that COPD in gold era is nothing like COPD in pre-gold. This is an important statement that I make, that COPD is changing, evolving as we are getting more information. And all this is thanks to the focus on COPD because of the gold time. So the term COPD is here to stay. So I rest my arguments there. Thank you, Dr. Surya. Dr. Suryakant?
Yeah, thank you, Dr. Chhabra. I think both the speakers have given their viewpoints, and now this is the time for the rebuttal. And for this, I'm inviting Dr. Varudkar first to provide his viewpoint as a rebuttal on the talk of Dr. Chhabra. Dr. Varudkar, please. So you justify and defend yourself
Are you
after
getting my
listening to
screen?
Dr. Chhabra.
There is
Yes.
something. Well, my screen. Are you? Am I visible? Audible?
Yes, you are visible
Visible?
and you are
Visible?
audible.
Okay,
You
okay,
are
fine.
visible and audible.
You're audible,
Dr.
Dr.
Chhabra,
Varudkar.
Dr. Chhabra, it is a wonderful presentation. I was really impressed with the information you have collected. And I had my own argument still as of now. Let us start with the definition. If the bronchodilator is still working on the respiratory, airways, then why not to make some changes in the FU and the partially reversible, the sort of diplomatic or political terms, make it okay, reversible in a late thing or something of that sort, or intensive bronchodilator, or maybe something. But this is poorly reversible. Is it's not really matching very well with the whatever presentation you have said. You are using bronchodilators on one hand in a very large amount, and there the justification in the definition is seems to be very meager. That is the reason why I'm pointing out this particular thing. Second is the bulk of paper you have presented is huge. Well, I was really impressed. I was not able to say something, but I remember one thing: having a huge audience against us doesn't mean I am wrong, because the one there was a precedence, the earth was flat and there were only one or two heads were saying no, it is round. It doesn't matter. Even if you say that thousands and lakhs of people are saying it, I would still say that yes, there are some errors, mistakes in this gold, and they have to be corrected. Then it will be really perfect. Okay, this is about one thing. Then the Venn and this Venn diagram is very useful diagram. But about this was thought about 40, 50 years ago. It is this is wonderful. But time has come to assess each and every element of that particular diagram. What are the reversible? What is this? And that cannot be done with the present working system and strategy of gold band. That is the reason. That's what exactly I want to say. That you have got so many features, so many things in the like loculi in the Venn diagram, but then we are just keeping them arbitrary. What is used? Which my patient, I have diagnosed this particular patient, and where am I going to fit it? That is the thing. Then that will decide what is the treatment I want to use. That's what the Venn diagram is correct. And precisely, I want to same things, same continue the same concept of using these settle the compartments. This is the thing. This is the thing. This is the thing. So that is the actually basic argument is same. Why do you combine blue bloater and pink puffer in one and same group? You make them different. You similarly make them simple different ways, so that there will be more accuracy of study management. Now the time has changed. There's so many modalities are there. You cannot say that now we are having that old concept are to still are useful. Now you that is the thing. Now all our patients will need correct diagnosis. Suppose somebody says my bronchitis airway is not responding to bronchodilators. Why are you pushing so many drugs? So there is going to be a problem in the consumer court. Why do you want to push it? Because by definition it is poorly reversible. So that has to be looked into the particular thing. And then let us define pathology. Pathology, how it depends upon how you look into that particular thing. Pathology, you have gross things, then okay, fine. 80% of the tissues are like this, 20% like this. But if you go for the more dissection of the things and more and more information, then you will have better understanding of disease, better understanding of management, better understanding of research, better understanding of outcome, and better things, everything. So that is what exactly I'm saying. I'm not saying that COPD doesn't exist, but it does exist. But it is not the way the gold is projecting us. It is like this. There are so many diseases. One is chronic bronchitis, emphysema, occupational diseases. These so many diseases are there. They are progressing in their ways. And at the end, somewhere they have got common in it, that is poorly reversibility of the bronchodilators, and it is so this particular thing, it has to be looked at that particular angle. So we treat various diseases, separate them. Separately, chronic bronchitis was not simple only chronic bronchitis. You must have seen that medicine people, they have got 4 or 5 varieties of chronic bronchitis. So you have to separate out what for what? For research, for finding better solutions, for finding reasons. That's why I am insisting on. I am not yielding to all your arguments. I am insisting on that it has to be corrected, it has to be followed, and let us go. Younger generation has to move. Thank you very much. Nice.
Thank you, Dr. Varudkar. I think
Yeah.
you have tried your best to put
Yeah.
forward your viewpoint as the counter of Dr. Chhabra's viewpoint. Now it's a turn of Dr. Chhabra. Dr. Chhabra, can you, of course, counter and give your input regarding this debate?
Yeah, definitely. I mean, it's always good to argue. Otherwise, if we agree on everything, then the webinar stops there, isn't it?
Continue.
We have to come up with provocative statements so that the fire keeps burning, right? So
Yeah.
now, Dr. Varudkar has a lot of objection about the use of bronchodilators in COPD because the definition says it is partially reversible. Now, the point is, we are not trying to reverse the disease. It is well recognized that the natural history of disease cannot be changed. Bronchodilators are not used to reverse COPD. We are not going to cure COPD by using bronchodilators. Yet, their beneficial effect is well established. They reduce hyperinflation, they improve quality of life, they improve exercise tolerance, they reduce dyspnea without the side effects of inhaled corticosteroids. So that is why after 2017, the focus has shifted from inhaled steroids to bronchodilators. It's not that we still live in that era where we used to call COPD as irreversible airways obstruction. Remember those terms, reversible and irreversible. That is 1980s concept of asthma and COPD. So that is long given up. The definition recognizes it's partially reversible, and we make use of that partially reversible term. And then we have to remember that treating COPD and asthma are not same. In asthma, one of the objectives of treatment is to normalize lung function. That is not an objective in COPD because we cannot normalize lung function. Right? So asthma is asthma, COPD is COPD. We use bronchodilators for whatever they are worth. And they are worth because COPD, after all, is a bad disease to have. So now if we have something which can offer them hope, why argue against it? Right? So it is, and that is why newer agents are being discovered. And in fact, bronchodilators are drugs of choice, starting with LAMA or a LABA-LAMA combination. And then for steroids, phenotypes are recognized that only if you have exacerbations or the eosinophils are high, then you use steroids. So the management has been refined over years. Second, you say that gold is keep changing. Definitely, that is the nature of science. New literature adds new information. So gold has to keep changing. Stage 0 was dropped. ABCD classification was introduced. So last word has not been said. And who knows what the guidelines of statutory documents of 2025 might bring. We are moving towards an era where there will be more personalized therapy. We are identifying phenotypes of diseases. In asthma, we are far ahead in this. COPD, we have just started. So these terms, blue bloaters and phenotypes, these could be looked upon as the initial descriptions of phenotypes in COPD. So COPD remains a heterogeneous disease. You yourself use the term heterogeneous. So it is a heterogeneous disease. It's an umbrella term. But these are allied diseases with a common presentation, a common causation, and common treatment. So therefore, these have to be discussed together. Majority of diseases these days are moving towards personalized therapy because phenotypes are being identified. We are lacking in COPD. Later on, endotypes should be recognized. Who knows, we might be using monoclonal antibody in COPD also 5 or 10 years from now. So that is the advancement. And that is the impact of gold. Just see my first slide. The number of papers before 2000 were minuscule, few papers per year. After that, 1,000-fold jump in number of papers. Why? Because gold has stimulated the interest in COPD and it has come out of the shadows of asthma. So gold is a positive development. No document is perfect, and they themselves recognize. That is why they keep changing, because it is, after all, a group of people who sit, discuss, they take into account literature, and whatever is considered superfluous or not useful is discarded, and new concepts are introduced. So maybe someday part of what you have said will get introduced into newer guidelines. We look forward to that. But we have to have a positive attitude that gold is taking us in the right direction, and its dynamism has to be recognized. That keeps changing. It's responsive to new information, not rigid. You're saying we don't go beyond blue bloaters and pink puffers. We can't go backwards in history. We have to go forwards. Let us identify more phenotypes and tailor the treatment to patients' needs. So that's it about the debate. Dr. Surya Kant.
Yes, sir. Thank you very much. I think thank you both of the speaker. You have given our viewpoint as well as rebuttal very well. So this is the time. Actually, still we have 22 minutes time. So this is the time that some questions to be answered from both speakers related to their talk from the audience and from some other inputs given to me. So the first question to the Dr. Varudkar is, Dr. Varudkar, according to you, there is nothing like COPD. Then what is it? Let me know. Let us know.
Okay. Well, there's a little gap. There's a breach in the communication. What I was talking about COPD in the perspective of the goals. COPD is there. I didn't say, they didn't say. It is a part of the terminal event of many diseases. It is a part of terminal. Say, for example, chronic bronchitis or emphysema is different thing, but many other occupations. So it's a part that this is progressing from very classical to towards a very common presentation. There it is COPD there. So before going to the stages of COPD, we have to evaluate all the diseases in that basic perspective of a disease, so that the management will be correct. And then when it comes to a stage of COPD, that some definition need to change and understood. There it is. That is the COPD's concept, and not the whole the thing like whatever gold is projecting. That's what I wanted to say. The disease, like what I mentioned, at the end what they are saying, COPD occupational, COPD infective, the same thing. What are doing? Same thing, occupational disease. Be clear in the understanding that yes, this is the occupational disease. Now it was pneumoconiosis or something else, and then over it has gone to this thing. Though this was a chronic bronchitis. It was like this. They have extensive tuberculosis, and now it has gone to say like this. Instead of having this whole round, the whole vague term, and then you think of various ideas. Let us have more open classification of diseases, so that what we have, suppose some disease there, chronic bronchitis there, or something like this. Some people think of the disease only as a chronic bronchitis, where some category may be totally curable. There can be some drugs for curing the disease. But if you combine all together, how it can be? It will be all waste of the energy and research. That is what I want to say. You have these diseases in our original sense, define them according to pathology, what we are finding, acute, chronic, and this and that, and say this. Then you take help of radiology. Who says? So that is the thing. You have to take this help of radiology, and then you diagnose the status of the disease, pathology, etiology, then the response of the antibiotic and bronchodilators, everything. This is how you manage the respiratory, and then at the end it comes to the COPD. Okay, is it clear? Thank you.
Dr. Chhabra.
Yes, please.
Dr. Chhabra, I think I must congratulate to you that you have defended the whole 25 years journey of gold development. Whatever the new have been added, what are the changes they have been added, and whatever you showed that chart that in 21st century, the maximum hits for the PubMed research or other research, they have been for COPD. So I think the gold has contributed immensely in the understanding of COPD, in the improving the treatment standard of COPD. And of course, it has also created many vista for the research, for the PG students, for the newer young researchers. But you also accepted that in epidemiological research, we are still using the term chronic bronchitis and the definition of old chronic bronchitis, as Dr. Varudkar had mentioned. So what is your viewpoint? Should we forget everything before 21st century, what happened, and all these old terms and literature and everything? Or we should always remember the history whenever we are planning the future research? What is your viewpoint?
No, see, we can never forget history. That will be at our own peril. History, we have to, because you have to learn from history, not forget history. And the first point about questionnaires, I'm afraid tools to study COPD epidemiologically have traditionally been questionnaire based. In fact, the Indian insert study, that is also questionnaire based. That is not based on spirometry. BOLD is based on spirometry, right? So our estimates on prevalence of COPD are based on a questionnaire based study, and there the only question, that's a standardized questionnaire about cough and expectoration. So chronic bronchitis is always part of the question. If you want to refine your tools, then you will have to add spirometry. And like BOLD has done, or the Pretino study in Latin America, they used spirometry. And because they have resources, so they could do field studies of spirometry in 40,000 subjects. We cannot do that in India. So Indian epidemiological studies on COPD have traditionally been based on use of chronic bronchitis as the term, and we have extrapolated our data from chronic bronchitis. But the other point about the history, now we look at COPD as more of an umbrella term, heterogeneous disease, and we are trying to identify phenotypes. We're not saying that emphysema is not there or chronic bronchitis, the blue bloaters are not there. In a clinic, you would still see pink puffer, you would still see blue bloater. They can't disappear. Only thing is that we'll use the term COPD for them, then using other tools, like if you have done a CT scan, you can identify emphysema in these patients. Or if there's a lot of cough and expectoration, repeated infections, then there's an element of chronic bronchitis. So these are useful phenotypes of the disease which have to be defined further. Phenotyping is strictly in the domain of a tertiary care center. A primary health doctor, he has to diagnose COPD and start the treatment because the number of patients is huge. Majority of patients will be seen by primary healthcare physicians, family physicians, and general practitioners. Now, for them, it will become very confusing if we start talking of phenotypes and those treatments. So these patients can be referred to tertiary care centers, but for the lowest level of healthcare, the common term COPD suffices. The standards of management suffice, so that at least we start diagnosing and treating these patients.
Dr. Varudkar.
Yeah.
Dr. Varudkar,
Please.
can you hear me?
Yes, speak please.
Yeah, Dr.
Yeah.
Varudkar. I must congratulate you. You as a hard-core clinician. You represent the many clinicians of this country. And majority of the practitioners, they are basically clinicians, not the researchers.
Right.
And you are the representative of the spirit of clinicians, chest physicians of this country, majority of chest physicians, general physicians of this country. And you opposed the treatment strategy of the gold, that if it is partially reversible, then why are you focusing mostly on bronchodilators? So what is your treatment strategy? I really, congratulate you that you dare to challenge the gold, the 25 years old international body under the umbrella of WHO. So you are really, you have done a very applaudable work, and I have already congratulated you. So my question to you is, rather, this is the question which echoes the voice of the pulmonologist, physician, and general physician of this country, and all the audience of this Chest Council of India, that if the bronchodilators are not the right choice, then what is your personalized treatment plan for the COPD. Although you don't like term COPD, but you accept,
Right.
rather you accepted that there is an entity. Yes, it may not be called as COPD, but there is an entity like this. So what is your personalized strategy to gold strategy?
You have hit a correct question, and I'm so
Thank you,
thankful
sir.
to you about this particular.
You have not raised any question
So
against the referee or moderator.
I'm
Okay.
thankful. Why? Because the bronchodilator in the very first setup that we have seen limited use of bronchodilators. Because you try one or two bronchodilators, if it's not working, then there is no point in pushing third bronchodilator, which we go on, which is commonly pharmaceutical company do it. So we have got 3-4 combinations. This one in by or IV, but these. Why? Because our concepts are still not clarified by the top people in the hierarchy. The girl, they have to put their aim. By now, at this particular stage, please don't use bronchodilators. This is time to use for something else. So what has gone wrong with this? Is there acquisitions? Is there something? What is there a collapse? Is there something? So you have to look for the other causes which are there, and then that is what exactly I am saying here. If you are using unnecessary bronchodilators, the clinician is happy. Yes, I have using five bronchodilators. What is use of 5 bronchodilators if not a single bronchodilator using? We are frustrated. See, listen, we are frustrated in private practice. The people every now they are putting pressure on us. Why not you have better, costlier drug, this drug, that drug? But if you give guidelines, like if there are other diseases, if bronchodilators are not really useful up to this limit is there, then it is going to be correct management. Understood? And then another stimulant is then what is going to happen in that particular thing. That's what I am precisely pointing out. If we want to find out what is going wrong in that particular COPD stages in the each leg, whether the bronchiola are affected, they are not responding, the musculature is not responding, the accumulation is there, the alveoli is there. You have to find out what is the reason there, and then they treat accordingly. This is the thing precisely I want to say. That is a very good question. And then our guidelines are not showing us any way out. They are even pushing us so many bronchodilators where they are not going to. But understood. So that we are wasting our money. We are wasting our resources.
Yeah.
We are wasting, maybe creating side effects. Okay. That is my thing.
Okay. Thank you, Dr. Varudkar. Very interesting.
A couple of points there. I just want to add a couple of points there on bronchodilators. See, we have to be realistic in our expectations. We are not expecting bronchodilators to cure the disease. So no point adding 4 or 5 bronchodilators.
Yeah,
we have to recognize that this patient is not going to respond.
Categorically in our guidelines.
Dr.
That has not been put categorically
I'm
in
the
the
referee. I'm the moderator. Through me.
Has not given.
I'm the referee.
Bronchodilators are not the sole treatment of COPD. Then we have to go to other modalities. We have to consider the use of pulmonary rehabilitation. We have to consider the use of home NIV, long-term oxygen, and surgical modalities. So the scope of treatment doesn't start and end with bronchodilators.
Dr. Chhabra.
Overuse bronchodilators.
Okay, Dr. Chhabra, question for you. There are 2 components of question from my side, and as I mentioned, from all over the country's physician and chest physician of this country and all delegates of this CCI debate. The first question is, people say that gold guidelines don't have the brake. They have accelerator only. They are actually, somebody told me a few years back, some international fellow in the conference, that the guidelines now have included A, B, C, D, and they will not stop at D. They can go up to Z. Number one, why we are coming with this complex guidelines? Dr. Varudkar's point is very much valid, that the guidelines, of course, they are being taught every year for the PG student. Younger faculty, they read because of the interview for the promotion. The B professor read because we have to give the lectures. Anytime you see Krishna will call a day and say, Dr. Surya, you have to moderate the session, or Dr. Chhabra, you have to speak on this topic. And some very good evidence-based practitioners, they are also use the guidelines in their practice. But majority of the general physicians the practitioner at the tertiary, at the level 1 or level 2, not level 3 cities, I would say, not level 1, level 2. And of course, the small PSC and CSC level. At this level, I think we need to have some simple guidelines, number one. And number two is that what is the role of now very popularly known as the dual bronchodilator therapy and the triple bronchodilator therapy. So just answer these questions. Number one, the complexity of the guidelines. And so they are not very much popular at the peripheral level. And number two, where are they indicated the dual bronchodilator therapy and the triple bronchodilator therapy? Yes.
Taking very relevant questions. It is a universal observation that the guidelines have not percolated down to the lowest level of healthcare. Not only in India, even US, yes. Vast majority of physicians have not heard or have not implemented these guidelines. Now, that is not an argument against development of guidelines. Only thing is that how these guidelines reach where these have to be used and implemented, that is a challenge for delivery of the message. Breaks, definitely. Old concepts have been given up, new have been introduced, like Gold has put brakes on use of inhaled corticosteroids. So we can't say that there are no brakes in Gold. About 5 years back, it was just like asthma. Now, there's clearly specified that to use steroids only in specific instances. So there are brakes which are inbuilt in.
So they have changed the gear.
Right. But they have moved away from
clutch.
But there's a major shift to change from steroids to bronchodilators. Yeah. You know, the other thing about adaptability, the document clearly say that every country has to use these guidelines to adapt and develop their own guidelines. In India, we used our own guidelines in 2013 in PGI, and you were there, I was there.
Yes.
So likewise, we have to revise and make this simplified according to our culture and requirements. So goal is not saying that you pick the gold guidelines and implement in totality. You adapt to local conditions. So that is something which we as pulmonologists, our associations, including CCI, NCCP, they have to do this, right? So the concept of guidelines is at least the principles are set clear what you have to do. The other question on management, dual and triple. Now, the triple brings in the use of inhaled corticosteroids. So starting treatment, if you are using an ABCD classification, which is, like I said, not difficult to use because you forget about CAT score. Use only MRC score and it's very easy to use. Just two things are required, exacerbations and dyspnea scale, and you can classify in ABCD. So in A and B and C, you don't require triple therapy. Single bronchodilator or dual if the patient is not responding. So the guidelines say that after initial therapy, if the dominant symptom is dyspnea, then there's a role for bronchodilators. Where there are exacerbations or there is an increase in eosinophil beyond 150 or 300 per micro, then you add corticosteroids. So for triple therapy, there are very specified conditions where it has to be used. So dual bronchodilator is usually the beginning treatment for patients. And in some of these patients who are having exacerbations or there is an asthmatic component to history, then there is a role for triple therapy. The mainstay of treatment is now bronchodilators.
Thank you. So thank you. I think this is the time to summarize. So I think the debate was very hot debate. And I think both of these speakers, they have done wonderful job. Dr. Varudkar has presented as a clinician perspective, and clinicians, you see the agony towards the understanding, towards the, of course, approaching for the patient of COPD. He was not satisfied with the gold current criteria. And I think Dr. Chhabra has done a very good justification for his talk. That actually, the evidence-based medicine is a dynamic process. He has already mentioned it's a dynamic process. So I think as per the collection and compilation of evidences goes every year and revision of this gold guidelines every year, I think new vista will open for the management. And they have opened in last at least 10 years. And as Dr. Chhabra mentioned, because a lot of endobronchial treatment, a lot of the vast intervened procedures and a lot of other interventions, and not only this, the surgical interventions, and most importantly, the non-pharmacological interventions coming into play. I think both speakers would agree that non-pharmacological interventions, including the pulmonary rehabilitation and yoga intervention, very important study has been done in AIIMS New Delhi by Dr. Guleria et al. In 2016. That, of course, it speaks a lot about the importance of pranayama and yoga as a part of pulmonary rehabilitation for the COPD patient. So I think both of the speakers they would be agree because the non-pharmacological treatment strategies, they are also coming in a big way. Earlier there was no smoking cessation strategy. Now the smoking cessation clinics are running. They are also running in my department at Respiratory Medicine Department of King George Medical University, and there are so many centers. I think every chest physician should run the smoking cessation clinic. And similarly, the latest intervention in the form of research. I think yes, the gold people, they should also include the clinicians' thought. And I think in so many diseases. For example, I will give you the example of ILD India Registry published on 15th March 2017 in American Journal of Respiratory and Critical Care Illness and Critical Care Diseases, Blue Journal. And when this study published, this had changed the whole concept of understanding of ILD throughout the globe. So I think India has started giving a lot of inputs in various respiratory diseases, and I think we can take the input of the Indian clinicians also, like Dr. Varudkar. He's very innovative, and he's very, of course, very positive thinker in terms of the need and demand of the Indian people, Indian physicians, Indian scientists. So I think we need a blend of the thought process of the Dr. Varudkar and Dr. Chhabra for the benefit of the chest fraternity, for the benefit of the medical fraternity overall, and for the community in large in India as well as globally. So I think now this is the time to stop the debate. And thank you very much for the Chess Council of India and the organizers for giving me this opportunity as a moderator. Rather, they have given the referee. So I declare this match as a tie as far as my referee role is concerned. So thank you very much. And the viewpoints of both speakers are welcome. And I think they will open new vista for the research, for the understanding, and for the popularizing the terms, popularizing the disease understanding and practicing the better treatment. So thank you very much, and good night to everyone. Over to the organizers.
Thank you, and very good night all.
Thank you.
Yes, sir.
Thank you, friends. It was a pleasure.